transferred to Medic 4 with belts and rails used. Once inside Medic 4, baseline vitals are taken, and very high blood pressure is noted. IV access established. 500 milliliter bolus is started due to the patient's high blood pressure, TKO. Again, just watch because that statement is confusing. I'm not sure whether it's a bolus or TKO. Patient is also complaining of nausea and keeps stating that she's going to throw up. Patient is given a nausea bag, given Zofran, reassessed, patient is transferred, and the blood pressure is improved. So,
Mike, if it helps you, you go in reverse order and we pack it, so work your way from back to front.
Oh, okay.
I was going to say, we've only got a few more left, and then we're going to go over some topics. So, we've only got 3 left. We've got 7:25, 7:30, and then 7:31 is what we're on right now with sick person. Medic 3 is dispatched for a patient who is possibly having chest pain and just getting over being sick the last few days. Upon arrival, the patient who lives in a group home was found sitting in a wheelchair. The caregiver was talking to the patient and advised that the patient was having chest pain and would keep reminding the patient that he was having chest pain while tapping the patient's chest. The patient was also in the hospital within the last couple of weeks for the same thing and was just getting over phoneonia.
Spell check.
Yeah, that was what I wanted to bring up.
Did you, Carol?
I can't spell pneumonia, and I tried 4 different times.
I like the
Spell check still
pronunciation,
did.
phoning pneumonia. It sounded like it was.
And it was jerkier than normal, according to the caregiver. The patient did not appear to be in any pain. The patient was helped up by the caregiver and turned and pivoted to sit down. During that time, there was not an opportunity for EMS or fire to assist due to space and how the caregiver was helping the patient. The patient was then strapped in ×3 and loaded into the truck. The patient was asked if anything was hurting. The patient would only respond by saying yeah. The patient did not appear to be in any pain and never did say that he was having chest pain, vitals, blah, blah, blah. So, the history taken on that was awesome. I like the fact that you mentioned the fact that the caregiver was prompting the patient. That was a very important part of the...
Can you hear him at first pumping him from the doorway?
Oh, are you serious?
We would be like, we could be out in the parking lot.
I'm not using
Anywho,
pseudo ever again. I'm using that term now.
do what?
I'm not using pseudo ever again. I'm using that term now.
Phoneonia?
I had Ed read it, he didn't say anything about it.
911 dispatch Medic 3 for a patient who has been having back issues for a few months and walked to her room and felt a pop in her right leg. Upon arrival, patient was alert and oriented. Patient stated she was walking back to her room when she felt a pop in her right leg and cannot put any weight on it. And when she tries, the pain is a 10. We looked at the patient's leg and found no abnormalities. We moved the patient to the cot via sheet lift, took the patient to the ambulance, took patient vitals, put a towel with a cold compress on the patient's knee. Here, she said the pain, on the patient's knee here, she said the pain was, where she said the pain was, that's supposed to. Transport the patient to safe antigenic ER.
North, State Road 7, 4395 North, State Road 7. 68-year-old male kept his foot open with a razor blade. Advised he has no feeling in that foot and realized he cut it. A neighbor is down there helping him. She advised he is bleeding profusely, bleeding through all of the tried to put on him.
Careful, guys.
Hey, just so you know, that guy's a complete asshole, so.
That's alright, so mine.
All on recording.
That's fine by me, I always want to be on camera.
Thanks,
Love
Jeff.
y'all. Bye, brother, be safe,
Be safe, guys. So, 911 dispatched medic 3 to a 68-year-old female that fell in the shower. Medic 3 arrived on scene of group home and found patient on the floor in hands and knees position, crying, grunting, moaning, yelping, and breathing rapidly. Medic 3 was able to communicate the patient for breathing control. Patient stated she slipped on water and went down and believes she hit her right side gluteus maximus on bathtub object of some kind. Denies loss of consciousness and only complains of right side hip thigh pain. Obtained trauma assessment with no findings of any kind. Was able to stand and walk to living room via upper extremity assist ×2, then seated and secured to cot via straps without incident. Was transferred and loaded into Medic 3 without incident. Vitals obtained and listed. Medic 3 arrived at St. Vincent Jennings and patient was unloaded without incident. Pretty straightforward. So the big things that I noticed from, and unfortunately Brooke and Tina left, but is that, and I was hoping more of the advanced would be here, is that our advanced providers are only putting in one IV attempt and then calling it a day on people who have complaints
We're
that
allowed to do that?
and especially like they'll put in one IV attempt and then call for a medic intercept for like pain control, and the problem is that Dr. Quall is asking us to use more IV Tylenol for pain control, and I think it's often forgotten, so that's something that needs to be worked on. Spelling is a big issue, grammar is a big issue, and then if, we'll go into a few other things. So, one thing that I wanted to go over is Indiana's medical power of attorney rules. So the power of attorney is something that is different from other kinds of advanced directives. The power of attorney only goes into effect if the person is incapacitated or unable to speak for themselves. So, and it has to be appropriately filled out and documented. I included the Indiana Healthcare Representative Power of Attorney form, and then there is this guide to understanding the medical power of attorney, and it has some myths and facts, and it says the agent acts within the limits defined in the document. The individual's wishes and preferences guide their choices. So it applies where the person can't make healthcare decisions, including temporary incapacitations. But the person does have to be incapacitated. It's not just because they don't like the person's decision. And I think that is something that's...
So basically, if they're able to make their own decision, this piece of paper means nothing.
Correct.
Could be kidnapping.
Yes.
And I'm like the preacher jelly, told me that.
Santa won't get his head up.
So, that is something important that I wanted to go over. I think it is probably one of the most misunderstood things in the EMS realm. So one of the other things that I wanted to go over is something that the state adopted, I think it was about 4 years ago. It's the EMS timeout report. It's called the MIST report. This is something that is good for when you give a radio report, and it keeps it brief. It's the mechanism or medical complaint, injuries or illness, and signs and symptoms, and then treatments. And that's just a real brief way to give things down and dirty. And it's also a bedside patient care report. It's also a good way to update incoming units, so that's more for, like, new providers and things like that. The other thing that I was talking about was knowing about hypertension and dehydration. I was talking about your report, Mike, the lady with the 267/136. And yeah, exactly, and the fact that a lot of the diuretics actually have mechanisms in them that as people become more dehydrated, their blood pressure goes higher and higher rather than the opposite way.
Doctor gave me shit about that too, because I give her a bolus of fluid based on, and her blood, so, yeah, I knew what I was doing.
And so, well, no, I know, and that was why I printed this out, was because a lot of people, they see a blood pressure that high, and they're like, oh, there's no way that she's dehydrated. And actually, a lot of those diuretics, based on the mechanism they work, the more dehydrated somebody becomes, the higher their blood pressure actually goes. And so that was something that I wanted to point out.
Yeah.
And then, so this was what I was talking about for you newer providers, was the narratives. So there are a lot of, as we go through these reports, you will see a lot of different narrative styles, and I pointed out a couple of them. So there's the SOAP narrative, which is the subjective, objective, I can't remember what the A stands for. Assessment, thank you. And then, procedures, thank you. It's not something that I use, so I can't remember it very well. And then there's the chart method, which Mel uses, and what does that all stand for? I can't remember.
C is chief complaint,
Okay.
H is history, A is assessment, R is treatment, and T is transfer. And then there's a D that's destination.
Okay. R, so treatment is RX.
Yeah,
RX is short for treatment. And then freeform, which is what a lot of us use, which is just kind of storytelling. But they're all a very valid form of report writing. And they all have their strengths, and everybody prefers a different style for different reasons. And so you will come to know your own style as you come into the EMS world, and then this next page goes over heat-related illnesses. It goes over the difference between heat stroke and heat exhaustion, just because we went through that really hot spell where we saw a lot of heat-related emergencies. I just wanted to remind everybody of the different heat emergencies. I wanted to give you guys a reference on that. And then the last one is something which really is really important in documentation. These are the Medicare approved abbreviations for clinical documentation. When I look through charts, I see all sorts of abbreviations. I know a lot of people, I know most of the people in this room try to stay away from abbreviations. And so I'm not talking to most of the people here, but just in case you are interested in it, this is the approved list of abbreviations from Medicare. And there are quite a few, a lot of them don't apply to us. So we will meet again in October. Let's take a peek at, do people like doing evenings? Does it?
I think break it up. Like I was saying, that like winter months do it in the evenings.
I think our back change in the evenings versus the daytime.
That's my feeling.
Because evenings, I can come in.
We can come in evenings.
Yeah, but you guys are cadets, you guys don't matter.
No,
I say
Well,
break it up.
guys.
my Mike is right.
So, let's see,
Andrew, what time do you wake up so we can get that figured out? 'Cause if
October,
we do mornings and you're not awake, it ain't gonna work either.
No,
does October 23rd work for people?
what shift is that?
I don't know shifts.
Hang on, I'll tell you. October 23rd, that's our shift.
Now, out of curiosity, because I only pointed this out because I have to deal with it all the time. This room is reserved certain times of the week. You know that, right?
Okay, so he said Thursdays are good for him.
I know, and I looked at September, never mind. I was sitting here going, why are you going Tuesday? Okay, never mind, my fault.
Got it in mind.
Does that work for everyone?
Are you locking it in?
Yes, does that work?
6 o'clock still?
Yes, sir.
That's a Thursday.
That is a Thursday.
And I'm assuming this is getting posted on the YouTube channel also?
Yes, it will. Alright, so before we depart, is there anything that anybody would like to talk about?
Did not sleep well.
I'm sorry. Your wife's out of town, so.
I don't know, I did.
I think you did sleep well this morning.